Hey everyone. We're letting a few more folks join. All right, it looks like everyone's in, so we can get started. Thank you all for joining us today to talk about what I know is a very present issue and question for a lot of folks, which is really how to make billing work for early psychosis teams. And we have two folks with really great experience and kind of expertise to share on this topic. So I'll do brief introductions and then hand them off to Lauren and Amanda to get us started. But first, so Lauren Fink is the Senior Director for Policy for the Kennedy Forum. She represents the forum on state and national mental health and substance use disorder coverage and advocacy efforts. So Lauren works with government leaders, regulators, policymakers, and consumer and industry stakeholders around healthcare access and consumer rights, which includes insurance coverage, crisis care, and youth and school mental health. Her work has led to the successful passage of a number of comprehensive state mental health consumer protection laws, which have served as models and been replicated in other states. Lauren's also worked in state government and consulted for city and county governments and nonprofits. So she holds a master in public policy from the Goldman School at University of California, Berkeley. And then we also are joined by Dr. Amanda Weber, who is a licensed counseling psychologist at the Brookline Center for Community Mental Health. So they're the director of the Cedar Clinic and also co-lead the Massachusetts Psychosis Prevention Partnership, also known as M3P here in Massachusetts. So currently, Amanda supervises trainees, conducts psychiatric evaluations for youth and young adults, and provides individual, group, and family therapy with the Cedar Clinic. And they were also very much a part of the efforts at the Cedar Clinic to get a contract, a team-based contract with a private insurer for the services that they provide. So thank you both for joining us. I'll hand it off to you guys to introduce a little bit more about your backgrounds here.
Thanks, Kelsey. I'm going to share my screen and hopefully I will share the right one. Okay. And sorry, one second. Okay. Can you all see an actual presentation?
Yes,
Great.
looks great.
Okay. Well, I'll start out. I'm Lauren Finke. Kelsey gave me a very lovely introduction, but I'll explain a little bit about the Kennedy Forum too, for those who aren't familiar. We were founded by former Congressman Patrick Kennedy and his wife Amy. When he left Congress, he's the author of the Federal Parity Act and is a person in recovery himself, and so really focused on ensuring both, access to mental health and substance use disorder laws, and in addition to some of the stronger parity laws that he helped enact and wanted to see kind of implemented with fidelity. So our portfolio has gotten much bigger over the years. It's pretty much squarely in the mental health and substance use disorder space, but we do a lot of state advocacy, federal advocacy. Sometimes we'll run state and federal bill or state bills, but a lot of our work is around implementation and kind of doing what we would consider sort of like the last mile of work that often kind of gets left behind. That's a big reason why a lot of these things aren't realized. So that's where we try to focus, is a lot on implementation, and then on emerging topics, trying to see where there's trends and things like that. So I'll talk a little bit about some of our projects that may intersect with some of the coordinated specialty care work as an aside, if anyone is interested, or thinks that that information will be useful. We can talk after the presentation, and there's some additional information in the slides too, but I won't spend too much time on our other things, but that we view them as pretty relevant to consumers and clinicians. So hopefully that'll be helpful to you. And I'll turn it to Amanda to describe. Well, I should say this first. This is our large vision. By 2033, this is sort of what the Kennedy Forum is, a goalpost they're moving towards, and kind of everyone in the field of mental health and substance use disorders or healthcare, we're trying to kind of get on board with this. So 90% of individuals screened, of those 90% receive the care they need, and then of that 90% are able to manage symptoms and achieve recovery. So very big goals. We sort of have a large plan on how we're measuring progress towards those goals. And I think where this just sits for us is so much in the screening and receiving care continuum too. So I guess we touch all of these things today, but this is how we're thinking about how we work with partners and what our vision and goals are for the next decade. Now I'll turn it to Amanda.
Thanks, Lauren. So I just a real high level. Cedar is a clinical high risk for psychosis clinic. We treat individuals from the ages of 12 to 30. We are really looking for folks who may go on to develop a psychotic disorder. And we sort of provide a very comprehensive assessment and evaluation, and then go on to provide for about 30%, 35% of folks that we evaluate, holistic care, so individual, family, group, case management, psychiatry, I'm missing something, coaching, school and work coaching for the young folks that we serve. And we're located in Brookline. We have been around for 15 or 16 years. One of the co-founders is, I saw her enter, Michelle is also here. So that's a little bit about us.
And both of us will be presenting today. I'll start us off, but really thinking about why this is important right this moment. Our view is that if mental health care isn't being billed or reimbursed, the power of a lot of these laws that have been built up over the last, decade really still remain unrealized. So I know I talked about these things being sort of the last mile, but I think being able to bill for services that are legally required of the plans to bill is so, so important, and also much easier said than done. And so we'll kind of go through today what the basis for a lot of this is, and then Amanda will talk about how they sort of got that done, and then how we can possibly replicate some of those key areas. So our goal, and I'll talk a little bit more about it in a second, but Cuneiform's goal is really to help the CSC clinics bill and get reimbursed via a team-based rate for all of these services that are sort of under the larger continuum of coordinated specialty care. Amanda will talk more about the progress that Cedars has made. And then really what we're trying to get at is that anyone can do this in their clinics if they, kind of get their things in order. And so we're trying to help sort of build those things up for you all, lots of resources and guides, things like that. And then also like how to talk to a health system partner, how to talk to your health plan, how to sort of negotiate on those things. And so those are all kind of individual items that I know that are without those, it feels really scary to just say, yes, you're doing that. So we'll go through those today too. A little background. I think given the audience, probably most of you don't need this, but this is also the background that we give when we're talking to health plans and to health systems too, who don't know this work. So you have a sense of sort of what we try to show. CSC, the recognized clinical intervention for first episode psychosis, supported by the federal government, has lots of research backing it. I think importantly, starting in around 2019 is when you see some of the things that feel like really good levers for coverage. So the APA approved CSC in its practice guidelines. The Meadows Mental Health Policy Institute issued a now pretty famous payment strategies report that recommended the use of one billing code instead of having to do like a bunch of fee-for-service individual codes and only get part of them reimbursed by plans. And then in 2023, SAMHSA issued a report on financing strategies, which was sort of the basis for a lot of the CMS introduction of the two HCPCS codes that are for comprehensive services. So one's a monthly rate and one's an encounter-based rate. And that really provided a clear pathway for comprehensive reimbursement for CSC without having to go through the fee-for-service models. Before that, there was really no way to force a plan to cover something because we didn't have a code for it. A little bit about the federal parity laws. So I have to talk about federal parity laws a lot, and they are never exciting to hardly anyone. So I will keep it short. But Everything that you need to know about federal parity is on this slide, which is that the laws simply require insurers not to limit mental health and substance use disorder coverage more than they do for physical health. So anything comparable on the medical surgical side. So that could be like visit limits, it could be co-pays. Those are the things that are like easy for people to think about. But it can also be things like big disparities in reimbursement. It could be things like inadequate or networks that are more inadequate than on medical surgical side, things like that. And so health insurers generally cover medically necessary physical health services in line with the generally accepted standards of care. So if CSE is the generally accepted standards of care, and there are clinical guidelines and research evidence saying that it is that for first episode psychosis, then it generally is difficult for an insurer to comply with parity and not cover CSC. That's kind of like oversimplifying it, but that is sort of where we sit in this, and the federal government has issued some rulemaking and things that I think make it a lot easier to make that argument. Additionally, there are state parity laws that are also requiring coordinated specialty care coverage. Those vary from state to state. Massachusetts state law mandates coverage, or their parity law mandates coverage for 13 health conditions. That includes schizophrenia, schizoaffective disorder, major depressive disorder, bipolar, a lot of the things that might overlap with someone coming into a clinic for first episode psychosis. So under this law, health plans have to cover a full range of services, including necessary inpatient, outpatient, and all intermediate services. So that is also really good backing, I think, that you have in the state as well. Additionally, and this is pretty recent, and I'm so sorry if there are people in the chat, I can't present and see the chat with my tiny screen. So we'll get to the questions if that is what those things are in the chat. I can't see them.
Not
So
questions yet, but I will
okay,
unmute and
okay,
interrupt
great.
you if we have some. Yeah.
Amazing. So what we do know is that many plans already cover CSC, and I can give more information about this, and there is more information on the appendix, but of this presentation. But the County Forum compiled new transparency and coverage data files, which are every health plan and health system has to basically submit information into this system. It's called the transparency and coverage data in order to have more. The federal government did this in order to understand more about rates and reimbursement, things like that. So these files are huge. They are publicly available. But for example, if I were to try to download one from a hospital on my computer, it could take me like hours to download it, and I might have to have a special system or something to open it. So they're not the most user friendly, but the county forum has started working on compiling those, and we have started by a pilot in Illinois to sort of see county by county what reimbursement rates look like and things like that. Why this is important for everyone here is that we were able to see from those H codes that we just talked about whether on the health system side, those things had already kind of been like default coded into the health systems coding systems, like their coding background. Because the thing that we hear a lot from providers is that the health system says, well, we just don't have that, so you have to use a fee for service code or something else, or a different CPT code or something. We know that actually the majority of the large nationally represented products have this coded into their backend system. So we know that Aetna does, Cigna does, Blue Cross Blue Shield, while United didn't. United partners with Optum for their behavioral health services, and there is an Optum memo that specifically calls out these things for coordinated specialty care. So that's a really helpful thing to just keep in mind, that these things are already kind of coded in a health system. It's not like the person you're talking to may not have any idea what's going on, but you can educate them, and then they're kind of built into their system. Something else too that transparency and coverage data revealed. So this is only in our pilot state, which is Illinois, but these are all with nationally represented products. So we have a good sense that these are probably about the case elsewhere too. Is that the percentage? Sometimes you can also find in those transparency and coverage files the percentage billed and what the amount billed was and the percentage reimbursed. And so that gives you a good sense of, even for these codes, when they were billed, like what percentage reimbursement do you get back as a clinic? And so what we found is pretty much the mean and the median are about the same, that it ranged from about 50% to 82% in cases, and was about hovered around 80% in general for both the encounter rate and the monthly rate. So the billing range, 50 to 82. I'll say for other CPT codes and other things in mental health, this usually ranges from about like 60 to 90%. So this isn't like terribly different than that. I think it's kind of at parity with other behavioral health. And then, 80% is actually not bad for reimbursement. So this is what we kind of know generally going into this across the country. So from that, you might be able to tell some providers are already billing. Not a ton of cases or not a ton of claims. In 2024 for those HCPCS codes, there was 83 claims across 35 commercial enrollees and then 21 for non-Medicaid. So we know that this means it's possible to bill. So we know that even though the cast iron is like barely seasoned, that it is there and seasoned and like ready. What we don't know is like who those claims or enrollees or anything is. So this is kind of where we start to lose the ability to granulate and show, oh, this clinic did this, which is why it is amazing that Amanda is here to explain how that works. So for us, this is according to specialty care clinics, especially ones in larger health systems, have these current contracts with those plans that I showed on the previous page, like Aetna and Cigna and United. They could bill their system's existing charge master rates and are reasonably likely to get paid within those, percentage of charge masters. That's oversimplifying it a bit, but I do think that is generally kind of the takeaway for this is that we know these things exist. We know that the health plans have them coded. A lot of this is on relationship building with your health plan, and trying to get them to, to not make that. You don't want to start out in a fight, right? You want to try to work with them on these things, and Amanda will talk about that too. But I think it's just really good background for like, it's not that there's, I think it often feels like no one ever is doing it anywhere, and health systems have no idea what's going on. And you are, as a clinician with limited administrative time, you have to figure out all of these components. And so hopefully building these together, you can kind of see what's ahead of you. This is going to get a little wonky, and I have this mostly so you can take a look at it later. So I promise I'll walk through it. You do not have to start reading all of this. What we did and we are happy to do this for individual clinics too. We did this for a Massachusetts brief that we shared out. Kelsey, if we can share that again, that would be awesome. But we essentially took we wanted to get a sense of what kind of rate you could reasonably back up with health systems, or sorry, with your health plan that you want to do this with. And so where you start, and I think where most people start and are familiar, if you're already a Medicaid provider, especially, you understand Medicaid rates. You understand what you can get back for that. You understand what services are included. Um, I just want to be very clear that Medicaid contracting and billing is much different than in the commercial side, which I think will become probably pretty apparent later when Amanda's discussing it. But you also don't have to just do Medicaid plus like or your costs or things that we often hear like, well, I need to know my costs so I can add like a certain percentage on. For commercial billing, that's not often how it works it's definitely not how it works in the medical surgical side, and it's not how it works in the behavioral health side, very simply too. There are all sorts of things that kind of come into play, like market factors and like how much you're paying clinicians and things like that. So, uh, all that to say, we started by calculating out what the comparable commercial rates are. Some states have a wraparound encounter rate that Medicaid or Massachusetts Medicaid does. A lot of states don't, and so we have many ways of going about trying to get a sense of what's comparable to that HCPCS code. So the Massachusetts bundled rates, 234 for adults, 240 for children and adolescents per encounter. And then there's lots of things that Medicaid experts have done to figure out costs of a clinic. So those are sort of the things that you would keep in mind just for setting what I would call like your floor of what's acceptable. And so you've got these things from Massachusetts Medicaid, and then you have, some of your costs and things too. I'm giving an example. This is just using McLean's hospital data. This is from the transparency and coverage files. So, you just keep that in mind that this is all public. We can do this for any health system or hospital. So you'll see here, these are the common CPT codes, often that clinics will be using or billing. We can also, look at which ones, if your clinic's not billing certain ones or is billing other ones. But these are the CPT codes for behavioral health. And then you can see the Massachusetts Medicaid rates for them as well. And then you can see what McLean billed those for commercial insurance. So, for the first one, 145 is about 2 times the rate of Medicaid. And so we kind of go all the way down and see that it's usually many multiples of Medicaid. I'll say in markets like San Francisco or Boston or Seattle or St. Paul or Los Angeles or San Diego, where we've sort of started a lot of these things, these rates seem to be pretty regional based, like a lot like a health system in Seattle might have the same kind of, or a hospital in Seattle might have the same hospital or multiplier as another hospital in Seattle. Those are sort of the things that we've seen. We can do this to see too with, because there's so many clinics that are interested in this. We could try to do this for Massachusetts too. But what ends up happening is it's about 3 times the rate of Medicaid is what McLean is able to successfully bill their commercial contracts and get reimbursed. Again, we don't know what percentage of that is getting reimbursed, but we know that this is their charged rate. And so 3 times Medicaid, if you apply that to the existing, even just Medicaid fee schedule for all the CPT codes, that's still even more than I think what most clinics are expecting. Um, Again, this is, based on, so for McLean, if you're thinking, all right, I'm going to bill for CSC, where do I even start? I have 3 times, like generally for other behavioral health codes, I already bill 3 times and get that reimbursed, and the health plan is okay with that. Like these are for contracts with health plans. So that's really good background information that before the transparency and coverage data, we didn't have at all. I'm hoping I'm not getting too weedsy here, but I'm just trying to make the point that like 3 times is something that's really great. In other markets, sometimes it's like 10 or 15 or 20 times. And I think people's eyeballs kind of pop out when they see that. But this isn't even just comparing medical surgical. Like if we really wanted to do it legally at parity, you would compare to physical health, medical, surgical wraparound services and what those would look like. And so that could also be helpful to do so that you basically show what the like horizon of what it could be is, and that this is sort of um, a middle ground. This is just more of that for calculating Medicaid. Again, with that right-hand column is just that 3 times the Medicaid rate. So just so that you can kind of get a sense of what this is for compared to Massachusetts Medicaid. And then here below, you'll see there's like that bolded sentence. I think that's the real takeaway. So using that multiplier of 3 times, Medicaid rates for hospital systems, the estimated billing ranges would be about 86 or I guess $8,700 per program participant per month. So if you had 30 participants in your program, you could bill $260,000 a month for your clinic. With these rates, just using that multiplier. So I know oversimplifying, but just to give you a sense of the realm of what you might be able to reasonably ask for under parity laws. I will mostly skip this, but you can come back to it later if you'd like. The additional considerations that you might consider are just there are other states who have built in wraparound rates, like specifically using these HCPCS codes. And what they did was do like partial month and full month encounters. And they use that like using the BLS, like labor data and wage data and healthcare costs, things like that. And a lot of states, or not a lot of states, the 2 states that have done this have been pretty transparent on how they've calculated that rate. And so California's Department of Healthcare Service has done this and has kind of opened up how they went about doing this. And something that I think is just interesting is there are 58 counties in California, and many of them are small and rural. And it just seems like you can kind of pick one that is pretty comparable for other states. And so we've been doing that too. So while it's not predicated on the Massachusetts Medicaid rate, if you were to sort of use that same bundled rate, um, something like uh, Suffolk County would be comparable to a really high cost of living county like San Francisco. And so those rates become actually even bigger. So you would see like it would be 1,200 a month for um, an encounter. So there's just different ways that I think we're kind of building out the time, not the timeline, but the range that is sort of acceptable under state and federal parity laws that you could reasonably ask for and present. And so I think this is a lot of just trying to like use our brains to think like we can bill bigger and we can't ask these things for commercial insurers. So no, under this, it would be about 300,000 a month. So a little bit more than the previous rate where we just used Medicaid rate. So again, just to sort of show the range of things that may be possible. Which I already kind of went through. So we started with the 260,000 up to the 312. That's something that I think is defensible pricing logic to work with plans on. And this is just a representation of that. So the current state of things about, how much per encounter you can bill. You see in Medicaid, you can bill in Medicaid, and people are doing that. And then for the commercial rate, if you were to think about doing it at parity with other mental health codes, which is what I just showed you, you can get much more than that. The commercial rate, if you're really comparing it to medical surgical wraparound, would actually be much, much higher. Like it would be like off this page high, but this is just to show, the kind of the reasonableness of having this using other CPT codes in behavioral health. So key takeaways here are that clinics are in currently a pretty powerful position to bill CSC under the state and federal parity laws. And then just another note that true parity under the laws would really be parity with medical surgical. So really trying to give us permission to ask for those things in behavioral health because medical surgical is kind of light years ahead in terms of how this wraparound billing and contracting has worked. Um, Here's my little plug for County Forms Billing Initiative. We are happy to work with clinics who want to do this to get any ducks in a row that they might need to get in a row. I am really excited to hear Amanda's part of the presentation because I think it'll show some of the hiccups and things that are hard, but that you can get around or that you can work through. And as we kind of learn more lessons learned, we're trying to build those into documents. So like, here's a document of FAQs for like your health system when you're trying to convince them to work with you, or here's, an FAQ for, how you would talk to your health system partner and like putting that into the charge master or different things that are special components of getting this kind of up and running. And so we have clinics that are participating and excited about it. It's always an open invitation to a clinic if they'd like to do this. And the target outcomes of that are successful billing using those wraparound H codes, so not really piecing together a bunch of fee-for-service or CPT codes. The goal is successful reimbursement for those things. We will create model communications with all those folks I just mentioned and model contracts. And the hope is to have sort of replicable billing models that can work. So those are the things that we're working on in that clinic together. I'll breeze through these things because I think this is also something that Amanda will be touching on and maybe we can go back to, but I think there's some like initial steps that we have learned for how to operationalize some of these things, like identify your existing billing structures, identify your existing internal staff and systems that you need to have on board. That includes like the clinician that would be listed on the claim, since you don't have to have every single clinician listed for every single service. Identifying plans that might be most situated to do this that we people sometimes ask us like how. It's like, well, which health plan do you feel like doesn't give you a horrible time for literally everything, or what health plan has said they're okay trying this or things like that, or do you have a really good model case that, like, if you have someone walk in and they have Aetna and it's kind of like a slam dunk, like perfect case to try to bill for, maybe you start with that. So really trying to figure out how to identify and model those cases for billing, creating personalized documentation, and then of course calculating your internal costs so that you know as a clinic what you won't go beneath. And I think the Medicaid things I just went through helps with that, but that's also an important kind of, all of these things are important for getting yourself ready for this. After that, you would do more like health system outreach once you've estimated your bottom lines. And I would say also once you've estimated or like had a good sense of like how to describe your clinic and what it does and what you need and how it can be sustainable. Like that's a lot of what's important for health system outreach. That first slide where I had like in 2019, all like that is something that like we always start with, because just even explaining what CSC is and why it's important and why it's the clinical um, treatment for these things, like that's something that you kind of have to, it'll feel like you're starting over and over again with every single new health system person, but I think it's because you have to sort of get through those things. And then we talked about this, and I'm sure Amanda will talk more about it, but just not being scared of a no as a first response. I think it's a lot easier, especially for large health systems, to say like, well, we don't really do that, or United doesn't contract with us for those things, and just ending it there. But there's lots of different ways that we can be responsive to those things and assure them. After that is when you would, once you have your health system involved, then you would have billing and health plan outreach to really try to figure out building a claim, outreach to plans, making sure that you have everything in your charge master to do that, and then identifying those like legal timelines. At the very end, I think this is really helpful of once you've built something, like what you have available to you as recourse, like if the health plan doesn't ever respond to you, or if you get told no, or if you get a denial, but for like, if I get a denial for medical necessity, what do I say? If I get a denial for like coding, or if I get a denial for like different, like wrong provider on the, like, how do I kind of navigate that using the, like in this, interesting new world with these HCPCS codes. So those are all important things to kind of work through too and be prepared for with the health plan. And the state regulator is also an amazing resource for this, and being able to sort of package something and know how to navigate the regulator for denials and things is an additional thing that County Forum is really well versed in, and actually how we kind of started in the CSC work. And so that's also a helpful thing that we talk about too. And then just kind of everything in the post-billing communications and kind of getting contracts and working with providers, which Amanda will talk more about, including the contract negotiations. So I'll let them start with this, and I'll hand it off to you.
Thanks, Lauren. So I did want to just highlight, first and foremost, this was an incredibly long process for us. I think we started conversations July 2024. We didn't even get a PDF contract until, I want to say, August 2025. And then there was another 60 days after some negotiations. We did officially launch with Optum November 1st, 2025. So I just want to spell that out, that I don't think this is like a quick process, and maybe that's because it was me as part of the process and it was just slow, or that we're a very small community mental health agency, so we were low priority. I don't know why it took so long. It just takes a long time. But the other thing I want to note is that I think that I really quickly in the start of these conversations realized that I do not have the amount of knowledge that I would need to have these conversations with folks. And so I very quickly brought in our CEO, Ian, who has done lots of insurance contracts before in the past, and then Kelly Madden, who knows everything anyone needs to know about billing. So she's our billing person. She does a lot of has had a lot of experience with negotiation with other commercial insurances in the past. And then we do have a wonderful committee here through MapNet, the finance committee. So I was in consultations with Monica Luke on multiple different occasions to be like, this is how I'm thinking about it. What do you know more than I do? And then trying to figure out how can we take what came out of that committee, what has come out of the Kennedy Forum and how do we implement it going forward. So lots and lots of conversations is what I want to say. And I also want to say that the reason why it was really helpful to have a billing person in these conversations is I'm a clinician first and foremost. I do not understand what insurances need to hear, and I do not know how to translate my clinical knowledge into insurance speak, and they don't really know how to translate their insurance speak to clinical information. And so I think what I noticed a lot of times was happening is that they would say something and I would misunderstand, and then Kelly would be like, that's not what they're saying, Amanda. This is what they're saying, which allows me to then adequately respond in a way that they can hear and shows the value of early psychosis services, right? So I'm just going to step you through what our process looked like, and happy to answer any questions after I step through this process. So Optum actually reached out to Cedar, and our first meeting was essentially Optum saying, this is why we want to have this conversation. They were very interested in piloting the new codes somewhere in Massachusetts. They had piloted in a clinic in Milwaukee, but there wasn't enough service users in the area, so they didn't really think it was a pilot going very well. And so I was like, oh, all right, well, if you want to pilot, here are the ways in which Cedar might fit in your pilot, and here are the ways that it might not. So I actually had to spend some time because we are a clinical high risk program. We do see people in the first episode, but I spent a lot of time talking about how clinical high risk and first episode are on the continuum of early psychosis. And I mean, if you all were at the MapNet meeting on Tuesday and we're listening to Bob talk about this, right? Like pulling where we're moving as a field is pulling people out of this sort of bifurcation of clinical high risk and FEP and into the idea that people are living on a continuum. So I really framed it as not first episode, but as early psychosis. And then I spent a lot of time talking about the similarities between the Navigate model of treatment and what Cedar does for treatment, and explain how it overlaps and how it doesn't overlap, and why in the reasons why it doesn't overlap, how it's okay. You can still bill us for a team-based rate. We still do a lot of really good work. You can still use us for a pilot. So we talked back and forth about this for quite some time in our first initial conversation. They left feeling slightly skeptical of me, I'm not gonna lie, but I was like, what can I do to prove to you that this is a workable model and it does work in early psychosis as we're identifying clinical high risk? And so they said, send me some data. Lauren, if you wanna click to the next slide, thank you. So we sent Optum not a ton of data, actually, if you ask me. And we pulled it from different sources, but we're like, this is who we're serving. This is the geographical area we're serving. We don't have a ton of Optum clients, or we didn't at the time, which became a negotiating tactic, actually, because we didn't have a lot, but we said, hey, what we're doing is we're willing to work with you to identify folks that are high utilizers in this age range that maybe you can see maybe experiencing psychosis, and we're happy to figure out how to do an evaluation or work with them. And so we were using that as a negotiation tactic of like, what you want is your high utilizers. You don't want them to utilize inpatient services. We're happy to work with you around that. And so then they were willing to come to the table over and over again. So I do think if that is something you can negotiate with, that is a reasonable tactic. And we showed, so some of our treatment outcomes around inpatient level of care, how long people typically stay in, the services that people receive while they're in our care. And so what we did with that is we explained how upfront people use a lot of our services and then over time gradually decrease in uses of services with us. Specifically that our first 3 months are very, very high utilization. And part of that is the evaluation service that we do here at Cedar. It's quite intense. It takes a lot of time, which ended up being important when we were contracting because we get different rates for different time periods based off the amount of time that we're actually in front of a client. We're going to see how that looks as we move through the next year or 18 months with piloting with them. So we sent this data out to them. Next, go ahead, Lauren, next slide. Then they brought us into another meeting with a bunch of regional representatives, so New England representatives as well as Massachusetts representatives. Had the same conversation we had in the first meeting, explained our model, explained how we're different, explained early psychosis versus FEP and clinical high risk. We went through our data. We talked about something that, if people aren't familiar, there's a collaborative of clinical high risk programs in Massachusetts that we've been working to develop over the last few years. There's some people who are also been helping with that. But a part of that, we've been creating a MapNet-like data collection system for clinical high risk. And I talked them through that, which they actually really liked. So one thing that Optum, and I'm assuming many insurance companies want is like, they want to see the quality assurance data. So if you are part of the MapNet system, or if you are part of the M3P system, it's talking about how we do have this quality assurance. We are monitoring this at a higher level. That seems to be important to them. Or if you're not part of those systems and you're outside of Massachusetts, having something that shows that you're monitoring the quality of the services that you are delivering is important for them. So we had this meeting, and then we heard nothing for multiple months. Lauren, go ahead. I mean, and I will tell you that I think in the commercial insurance's mind, like, we don't serve a lot of people, right? We are low, even if their service in their mind, their service users are high utilizers and they would like to drive that cost down. This is how a commercial person is going to think about it. We don't serve a lot of people, so we are low priority on their whatever it is that they do in their day-to-day. And so I would have to reach out every 3 to 4 weeks and be like, hey, do not forget about small Brookline Center, Cedar Clinic. Do you want to meet again? No? Okay, I'll bother you in a few more weeks. So like, I think Lauren's thing is like, don't be dissuaded by the no. Don't be, like, just keep going, because they, at least for my experiences, they will come back to the table. All right, so then I met Deborah. Deborah in Optum oversees all bundled rate setting in Optum. So what I needed to do with her is convince her of all the other conversations that I just had and why we're a value-based system and what value we have and how can I show you how much worth we are here at the Cedar Clinic and how much this is potentially helpful. So what I did is I spent a lot of time coming up with different models to negotiate around and talk Deborah through. So Kelly and I analyzed, what are we currently collecting for fee-for-service? What does fee-for-service not currently cover at all? And what else do we need to cover for sustainability? And so we took a very basic fee-for-service model, and then we compared it and utilized the Kennedy Forum. Kelsey sent me this Excel spreadsheet that has broken it down in more of a, it gets you more of that like hourly rate. It shows you like what you can actually get. And so we utilize that model as well to try to figure out what can we pitch to them and in what ways can they hear it. And so we had different models and we were thinking out of the box around coverage around this. And so what she did is, prior to the meeting with Deborah, she shared out this template about how they think about bundled rates, which is very much in CPT codes, like this code, this code, this code, this code, this code. And then what we did with our productivity data that we've been collecting for multiple years is we said, okay, here's this code, this is what our productivity is, great. And that's not going to cover our sustainability. This is what we need to be sustainable. So we met them and then we said, this isn't going to work. This is what is more workable for us. So we had this like back and forth conversation about units, lots of units were talked about. Again, I'm not an insurance person, so I'm like maybe not the best around this part of the conversation. But we did get to the place where in coordinated specialty care, supervision, training, the team-based coordination, the team-based meetings, we were able to articulate to them about how important that stuff was, and that this is part of if we don't have this covered in some way, this model isn't sustainable, and you will not continue to see the outcomes that you actually want to see, which is that these high service utilization people will not utilize your services. So we kept going. I don't think the insurance company cares. Maybe that's a little bit too cynical. The insurance company cares about saving money. And so you constantly have to show them that what we are doing is saving them money. And while that doesn't maybe align with our values and ethics as like people who serve clients, making that translation back to that is a very important thing. And that is one thing Kelly and Ian constantly helped me do, because that's not particularly how I think about clinical service. So that was really important for me. Okay, I think that's probably good about how we were thinking about the negotiation and the modeling. Okay, next slide. And then we waited for more months. I think we waited 6 or 7 months at this point. And I bothered Deb multiple times. And essentially she told me, you're not really high volume. You're a really low priority for my team. I'll get back to you. And I was like, great, I'll just keep bothering you until you get annoyed and then you push it through. I don't know if that's really what happened, but that's what I felt like happened. And part of this back and forth that I think is actually really important, and this demonstrates like, don't be worried about the no, I think a lot, is that at one point she sent me an email and she said, hey, just confirming that the diagnosis codes that you'll be sending us will be along some sort of schizophrenia spectrum diagnosis. And I said, no. I said, what, we talked about, clinical high risk is a little bit more of a catch-all than what your traditional PhET program looks like. We see people with depression, social anxiety, bipolar disorder, all sorts of things, anxiety, whatever. I was like, I need you to increase the diagnosis code pool. Otherwise, I don't actually know if this is going to work for us. And then they came back and they said, okay, great. As long as it's not a primary substance use disorder, we're fine to, and an eating disorder, we're fine to cover this. And I was like, okay. And I think on multiple occasions through my process of negotiation, my tactic was, well, I'm going to ask, and if they say no, then I need to figure out another way to ask them. So I know that like maybe that is like trite, but that is actually very true. They will try to tell you no, or that's not possible. And then it is upon you and maybe the team that you're working with to figure out how to get them to a yes or get them closer to a yes. And so some of my negotiation stuff is like, well, if you won't do it now, can I have access to your claims data during the pilot? Will you be open to revisiting this as a negotiation tactic or a negotiation later on in the thing? And they could say, they said yes, but they could come back and be like, we're not negotiating on that, and that's fine. I tried. But I think that there are ways to keep people at the table and keep people open around it that I think we just have to try. Okay, next slide. So then the next thing they did is in August this year, they sent us how they were going to do the bundled rate, how much it was going to cost, what was included in all of that. And again, we went back and we were negotiated between services. So some of the services they overstated for us, some of them they understated for us. I made sure that, again, we were talking about supervision, team meetings, and training needs to be covered. And so we had a negotiation around that as well. I will say my experience with Optum is they were quite flexible and they said yes to a lot of things that I asked for. I don't know if that's true across all commercial insurance. I don't know if that's true for everybody who talks with Optum, but I will say I had quite the pleasant experience with them. I did not feel like I was fighting them every step of the way. I actually felt like we were partnering together a lot. And again, I don't know if that's because of the people that I was working with or because they did say they wanted a pilot, so they were being more open about stuff, whatever. All right, I talked about bring your billing person already. Yep, you can go to the next one, sorry. So these are our next steps. From the point that we signed the contract after a month of negotiating with them, we had 60 days for implementation. They had to do a lot of work on their end to get their system ready for stuff. We have 2 points of 2 points of authorization at first month, and then authorization at 3 months for every 6 months, and then we authorize every 6 months afterwards. We have to provide our measurement-based care data to Optum. I think that's actually it. And then we set meetings for quality assurance on both sides. So we come with our measurement-based care stuff, they come with their claims data, and we talk about it. And we talk about the service, we talk about, does anything need to be changed on our end or not? I will say one thing that I didn't know was a possibility, but it is how they're doing their contract, and I think makes sense, is they're not looking for outcomes per client, they're looking for outcomes per average client. And what I mean by that is like, if 3 out of 6 clients receive coaching, that's good enough for them. If 3 out of 6 clients receive family therapy, that's good enough for them. So average amount of services, average amount of outcomes, which I think is good because we all know that like we work with clients who have different trajectories in their mental health and their recovery. And so some people might utilize inpatient units for a few more months than maybe another client. And so they're looking for this average utilization. And I thought, I mean, again, I don't know anything about insurance. So I thought that was nice and really responsive to our clinic and clients' needs. So we went live November 1st. I will tell you, we called Optum to authorize 5 people, 4 people, 5 people, because we only have 5. It's 5. And their comment back to us is, we don't know what you're talking about. What team-based rate? You don't have to authorize this. And then we reached out to our Optum people and they're like, oh yeah, no, you need authorization. Wait a second, send us the information. And then we haven't heard back from them. So the saga continues, the waiting continues. I think that this is just a systems hiccup, and maybe I'm just being optimistic with that. Let's hope. All right, I think that was what I had. Yep.
Yeah,
No
thank you
questions.
both. And Amanda, for your kind of ongoing work to figure this out. It's interesting to hear, it's still a kind of work in progress, but there's been so much that has happened in the past year. And hopefully, I mean, that since you guys are really the first doing this, that smooths out some of the road for the future.
We can cross fingers that it helps smooth out everything.
Yeah. We had one question in the chat a while ago, Lauren. So you're talking about really how to identify who to start with. Obviously Optum in Mass has been the first to really work with us. But Ken had asked in that transparency data, can you see how many different insurers paid those claims? Is it just like 1 or 2 that are really working with people or?
Yes, we can see. So that's where those numbers came from, or that's where we've identified Aetna, Blue Cross Blue Shield. And again, this was just in our Illinois group, but
Mm.
I'll just talk about. So in Illinois, it was Blue Cross Blue Shield in Illinois. It was Aetna. It was I think Cigna was the other one. And then we didn't. This was just. This was just ones where it was coded in, and then we could identify how many instances. I'm pretty sure. I think that was not disaggregated from the first. But it is Illinois data. And so where there are like regional products, which is often actually where I think sometimes regional providers tend to be more willing to do this. They have smaller markets. They're trying to figure out how to do this. We don't have that information. It doesn't mean that if it's not listed that they won't do it. They are also because it's a HCPCS code and because often HCPCS codes just get like coded in the back end. And so even if Optum wasn't doing anything with it, they had it somewhere in their back end. They had to do clearly from what Amanda said, they had to do a number of things to like get a rate around it and try to figure out what that looks like for opening up that pathway with the provider. But usually what happens is just whenever the CMS or the new fee schedules come out, they just put all the HCPCS codes that are in their back end. And so We feel pretty good that for the national products, they have those. We are, and it's called parityindex.org, where you can kind of see the transparency data and look around and you can see reimbursement percentages and things compared to medical surgical. And I have a slide that I can show on it if people are interested. But that's just in Illinois right now. But in the new year, we will be launching that for the whole nation, like for nationwide products. So that will be something where you can like click on, understanding what these reimbursement disparities are. And again, it's all just so that you have information that makes it a lot easier to negotiate and show your standing. Like even if we didn't have any of these things under state and federal parity laws, we could do that. And the health plans, and I talked about this a little bit, but like it's important, like network adequacy is something that is huge. It's a big problem for plans. They constantly are talking about not having adequate provider networks to work with. And I think that's where we're sort of like, well, you're a provider that's willing to work with them on a service that, as Amanda said, is, if it's not there, then they're expensive users of the rest of the system for the health plan. So I think sometimes like sort of building that in helps, not to get too far off of the original question, but like yes, we have those like 4 plans that we know have it coded and we're accepting bills for it. We don't know where and we don't know what providers, apart from the state. And but that doesn't mean, sorry, that's just, sorry. That doesn't mean that you can't you know work with another plan on this. It just means that you have less information about whether it's coded in the back end of their system and what their reimbursement is. However, the transparency and coverage data does show you a lot in terms of like you can look up, especially if you're working under a health system, you can look up what your health system billed. You can look up down to like each CPT code, like how often it was billed, the reimburse rate, the like percentage, like those things I think are really helpful for sort of building the cost case, for just how much this, the health plan is billing of or accepting of all these other things too. And so you're simplifying it for them as well. I think it's also like the user of the system costs money, but also it's not like they're not reimbursing for other services that they have to anyway. So I think that hopefully that's not too convoluted, but yes, just because other insurers aren't on there doesn't mean that they're not able to do that. And we know that by taking the health system data.
Right.
In which states were Medicaid claims paid through these billing codes? All of the information I gave was our Illinois pilot, so we'll be releasing this for the national level, and it's looking like it'll be pretty comparable across the board. It's not just like special to Illinois. The exception of that might be the Blues, actually.
And I wanted to kind of clarify because these are kind of two different processes. And Amanda, kind of from what you shared, it's very easy to get bogged down in the like encounters or like the units or the little pieces. But Lauren, kind of what you're saying is we know what Medicaid is paying for kind of a comparable service, the like day rate for a CBHC, like mental health services, which is a team-based kind of thing. And then we know you can go into this giant, multi-megabyte transparency data and see, well, this is how much this specific organization is charging kind of above the Medicaid. And you can kind of extrapolate that modifier on top of those to say, okay, well, here's kind of what a reasonable rate would look like. Although it sounds like there does need to be more work on the back end of knowing, how many folks you have in the clinic, how many staff you have, how many encounters, et cetera. But how would you, Lauren, pull that into like those kinds of negotiations or conversations saying, here's just our modifier to Medicaid, and this is what we would, other similar things are receiving at this hospital.
Yeah. So do you mean conversations with the health system or with the health plan?
Yeah, I'm thinking in just like negotiating for a rate, right? Because those numbers are quite a bit higher than I think most people would expect they could ask for.
Yeah.
So, yeah, how do you make that argument?
Um, So I guess I'll start with the argument with the health system, which is,
Hmm.
um, and I'm going to go on a limb here. I do not know everyone's clinics that are on this call. This is just based on what I've seen. I know that for so many of us, it's if we wanted to make the big bucks, we would have maybe not gone into this specific part of the field. We would have, I don't know what the big bucks equivalent is, but like a lot of us are here out of the like, we really care about this population and providing this care. It's complex, it's really hard. Getting your clinic to even be like accepted in a part of a health system is very hard and has taken so much work for so many folks. And then having to keep that afloat every year and handle all of the numerous billing craziness that is like dealing with Medicaid changes and federal, like all those things I realize are so real and really feel like hard pressures, and the administrative battle is all wrapped up in that. I think that can sometimes make us a little bit scared to come forward with like, I want to risk this. Like I want not the clinic, but like I have basically made do like just kind of pulling along for this much time. It's a lot easier to just keep doing that. But I think what we're seeing now with like kind of pullbacks in Medicaid, or for a lot of folks who had like in some states where they had these like I think Massachusetts was one where they had like private or like one-time dollars or whatever, those disappear, and then you're like, what do I do? There is like no other option but to sort of move forward and try to figure it out. And so all of that information I gave, I think is I'm hoping will be helpful for one, understanding what your baseline is. Like, what is your like, cannot accept under this rate, it wouldn't make a difference anyway. And maybe that rate is zero. Maybe it's like literally anything would make a difference, and that's good to know. I would not tell that to the health plans. But when you're talking to your health system, I think showing them the business case of like, if we can do this easier, if we can like build this out, like you may never be a clinic that's like a cardiac clinic that's making the health system its money, but under parity rules, like there really is no reason why you wouldn't be, like why you shouldn't be. And so you're not asking for cardiac clinic levels of like money making here. You're asking for sustainable levels to keep you going, where you can build and train your staff. And like all these things are kind of hard to do in a fee for service model, but you can do them in a um using that wraparound code. And so thinking about like what you build up to explain to your system that you're interested in making this more sustainable, and you're interested in this having money come through it that makes it so that you can build out a clinic for these high risk and high needs like folks, like that's really, in my experience, when you talk a health system and they once they get that, like they're fine with that. Like in terms of what Amanda said about like building the business case, like you do have to do that with the health system as well. But it's because they're just trying to figure out how they would have it like fit in their ecosystem. And it might be talking about it in a bunch of different ways to get them to understand how it fits in their ecosystem. But before you even get there, showing them the value of the work and like what it does and why it's important, and you know, using that transparency and coverage data too, I wonder if we could also just build in like, here's how much you're building, like this population for like emergency care or for inpatient care or things like that, and like what the comparable codes are to really show like this is cost effective to the system. We haven't yet had to do that, I think, because usually the health systems understand it before that point, and they're not the ones you have to like really, really try to convince. You have to try to convince them that it's possible to put those codes into the charge masters and to make sure that it's reflected in the like health systems data, and to help you help with the contract negotiations and things like that. So that's with the health system. And then with the health plans, oh sorry, man, do you have something you want to add?
You can, I'll let you finish. Yep.
Okay. And then with the health plans, like all that information, I think is helpful to show like if I were to start it brand new, I would say like, here's our reasonable, like in our existing contracts with you, with other behavioral health, this is sort of that larger, like between this range and this range, this is what we think our value is. So therefore, we are asking you this range. Like, I would not give them your costs. Like, that's for you to know. Like, I think there are components, and Amanda, maybe you can jump in on like that's very specific costs and things that you did need to show them and how you couched that. But all the stuff I went through is really like for your internal purposes and getting everyone on board with the health system so that you can get in a really good spot to begin those negotiations with health plans. Because as Amanda kind of walked through, like it's going to be pretty individual and you have to be prepared for whatever they're asking or saying and giving something that isn't. It's just not, I guess my whole summary is like it's not Medicaid. You don't have to like open up your books and say that you're like at baseline. Like commercial contractors aren't really doing it that way. That's not how they negotiate with hospitals. That's not how they negotiate on the commercial side for any of their other product. And so it doesn't surprise me that Amanda's like, they were open on different types of rates. Like, yeah, because they're not doing it based on cost. So like you shouldn't have to give them that. You need to know that. And your health system needs to know that, but they don't need to know that. So Amanda, I don't know if you have more you'd add.
Yeah, so I would say to answer your question, which is like, I never actually gave them the cost of anything because I did, to Lauren's your point, which is like, we undervalue ourselves all the time. And I didn't want to do that. And I don't know what they're going to value us at. I knew that if they did undervalue it, I would try to bring it up to what I thought it needed to be. So I would just say things like, part of coordinated specialty care is these things, and we need to figure out how to cover them. And these are the people who are a part of it, and this is the hours it takes.
Yeah.
So I didn't put my own cost to it because I didn't think that was a good idea. The other thing I will say, Kelsey, is that we are like almost tripling what we're making a month per client.
Wow. Yeah.
And so
And is
like,
that just for the Optum folks? Yeah.
so like we were able to get to something that I think is a reasonable starting point. I think there's more room to negotiate though, to be quite frank, though. And I know that there are people on this call that have a lot more power and weight than we do here at the Brookline Center. And so like, I don't know, lean into that a little bit. I think notoriously community mental health organizations have very limited negotiating and contracting power. And I think that's, I'm not saying that I experienced that, but that is just what I've heard. So I think if you have more negotiating power, you should definitely use it.
And I'll say too, if folks that are interested who maybe do have more negotiating power, like for example, one of the health systems we worked with in California, their rates were like much higher than that 3 times rate. And one of that reason is because they had a ton of negotiating power in the region that they were in with health systems and or with health plans, and that there's no reason that that shouldn't be reflective of other behavioral health too. So to your point, Amanda, I think that's really important. And I'll also say too, we've been talking a lot about health systems. If you're not doing this with a health system, then it really is just you're going to have to figure out a little bit more about how you would code it in your system to like kind of fast forward to that part where you talk to the health plan on this stuff. So Amanda, I don't know if you have anything that you would add there because with health system versus on your own.
I don't think so.
Okay.
Yeah.
So yes, you can absolutely do it. In some ways, it's harder because you will have to do the admin stuff yourself, but it sounds if you don't have a health system above you, then you're also not going through an numerous amounts of climbing the ladder to talk to like 1,700 different billing people, which sometimes happens with the health system. So like I think you're just trading some things for the other, but all the information that you would need to know, you could reasonably get and have available. So happy to talk to you, Brittany, on that comment.
Yeah, I was gonna just bring that up because I'm sure Brittany's comment is relevant to other folks here. But for clinics who want to do more of this, can you repeat what the Kennedy Forum the next steps with the Kennedy Forum would be?
Yeah, so reach out to me. I'm Lauren at thekennedyforum.org, or you could just bug Kelsey and then she will bug me or
Yeah,
whatever.
I also have Lauren's email.
And like being a participating clinic doesn't mean like we are like expecting all that. Like it really is your wanting to try, you have the people that will come to the calls to sort of like think through these things. We can work on specific documentation. Massachusetts is one of those states that I think enough folks have expressed interest in, that we have like Massachusetts specific things, which is what I kind of went over earlier in the call. Those all I think can be helpful, but like, if you want to get like specific, transparency and coverage information for like your region or where you're at, we can do that. We can kind of ballpark it, if you don't have a health system that's reporting on it, but most everyone has to report on the transparency files anyway, so there's something that we can work with. Um, and then we can also do it by region, like I showed the California region that was equivalent to Boston, and that was kind of like the high end, right? Like we can kind of build that out for whoever wants to, but those are the kinds of things that like we don't really know what you need unless you're talking with us on those things at every step. And so that's why we kind of have this billing initiative. So we would ask that you would like participate in that, which are usually like individual at this point, still like individual or state specific calls. And then we do an occasional like group call all together, but it's not meant to be, I'm not trying to put more admin burden on you for calls on Zoom, certainly. So it's a low lift in that way.
Thank you. Other questions folks wanted to bring up? Yeah, great. So why was Illinois chosen as a pilot state, and are there other states who are making progress on the CSC rate negotiations?
Great question. Illinois budgeted money for us to do it. So it could be, if there's anyone who's interested in working with advocacy groups in Massachusetts, it could be a like budget request or something that kind of comes through that way. That does not have to happen. We are trying to build it out nationally so that we have kind of a good sense of what national products are, right? Like Aetna in one or Optum in one state may not be all that different than Optum in the other in terms of what they're able to do. We just started in Illinois because that's where we had the funding. We are expanding into other states as they're interested and like actively working with, groups that might want to fund that. It is, as I said, the files are so huge that it does take quite a bit of our like just server like costs and things and time. So that's kind of why we've primarily started in a pilot in Illinois, but they were interested in that. And also their regulator was interested in outcomes from that. And so we were able to kind of like pull some of that stuff out and like give it to the state regulator. So I think that just because you could do that in Massachusetts too with like interested parties and things. And then in terms of other states that are interested in the billing things right now, we have Minnesota, Washington, California. We have folks in Massachusetts, and there is one more. There's some other smaller like folks that like states that they're participating, but they haven't yet like had conversations with their health system. So there's about 30 people.
Mm.
There's a question for Amanda, so I'll let.
Ken, there were so many surprising things about this process. One, that they reached out, I was surprised. So there. Two, I mean, I really had to make a case around clinical high risk being early psychosis, being something worth funds, right? Like, Ken, you've been in the early psychosis field enough to know that like there's a lot of varying opinions about clinical high risk being on the early psychosis continuum, and I think there's good reasons for that and not so good reasons for that, in my personal opinion. But like so I think that having people buy into that, I think that quote unquote coordinated specialty care isn't necessarily evidence-based for clinical high risk. So I had to talk about like the differences between what we were doing and what Navigate's doing and why it works in our population. And these are our outcomes that show that it is working, right? And so like, again, surprising, right? That Optum and all the various people were continuing to come to the table around it. Like, I think that, I think Cedar was going out on a limb a little bit around this, right? And so I think that people we're like, yay, like, let's do it. It was a nice surprise, right? One weird little surprise is that I didn't know that there would only be one copay a month for clients and their families instead of every encounter, which is huge for families, right? Like, if you're seeing a provider 2 to 3 to 4 times a week and you have to pay a copay every time you see that provider, and now that has just gone to one copay a month, like that is a ton of money saved by an individual. Yes. So I love that for our families. I mean, I'm surprised we signed a contract. Like, let's be serious. Who am I? I'm a random director in a clinical high risk clinic that's in Massachusetts in a small, like, yeah. And I think, like, to be fair, MapNet, the Kennedy Forum, like, people on that finance committee, there are so many people who have done so much work for us to, like, launch from. And so, like, I'm also very super appreciative of that. And anytime that you can, like, have this new thing happen with insurance companies, I think feels surprising to me. Because again, I think I'm not in the business of insurance. I'm in the business of treating people with early psychosis. And so, like, putting those one-to-one, I don't know, Ken, I have tons of surprises. I could probably go on forever.
Yeah, I'll echo what Faith's saying. That's amazing about the co-pays too. It kind of shows the real impact, not just on the clinic, but also on the like clients and families. That's huge.
I think it's huge for families. I think
Mhm.
especially for families that have, like, I don't know, I just think it's, yeah. So big win for them too, beyond, like, keeping our kind of clinics around.
Yeah, any other questions from folks? This has been a great conversation so far.
Hi, this is Monica. Can you hear me?
Yep.
Yep, you're coming through.
Yeah. So sorry, I've been driving, but I have been listening. And first of all, I want to thank Amanda and Lauren for doing this really important presentation. But there's a couple of things I really kind of wanted to highlight. One is following up on what Amanda just said, right? Is that the HCPCS codes are for coordinated specialty care, not for clinical high risk. So the fact that Optum wrote a contract with Cedar for clinical high risk is another bridge further down the road. So it's just extraordinary that that's where we went first, right? It should have been easier to do coordinated specialty care. So for those folks who are on the call that are part of a coordinated specialty care clinic, it's that much easier, right? Because we do have HCPCS codes and we do have this acknowledgement that it should be a team-based rate. So I really want to highlight that for folks and make it clear that it's really amazing that Cedar accomplished this for clinical high risk as well as coordinated specialty care. And then the other thing I kind of want to say is that this was the first time through. So all those wait periods and all um, the time it took is partly because Optum is learning to do it. So if a clinic is doing it for the first time with, say, Blue Cross, they might also find these long wait times and barriers. But as each clinic sort of goes through this and smooths the path, it's going to get easier and easier, right? They're going to be accustomed. They're also going to know whether prior auth is needed or not, and all of those kinds of things are going to get smoothed out. So we do hope that with the support of the Kennedy Forum and MapNet and the MapNet finance groups, different clinics are going to feel like they're ready to take the plunge into this and smooth the way for the rest of us behind us. And then kind of the last thing I want to point out is, Amanda, you mentioned, and I was curious about this, talking about the number on average of family coaching and things like that. I think that should go away. I don't think we're going to need to report back what services you give. The whole point of a team bundled rate is what those individual services are is not relevant to the health plan. What's
I
relevant to the health plan is that people are getting the service, they're getting better, you can show the quality, and you made the point about high utilizers, that you're keeping their high utilizers out of the hospital.
Yeah, Monica, I agree with you 100% about the average user. And I also I would personally want to keep it around for just a little bit longer so that I can do some negotiating on different parts of the contract we have. But yes, I think eventually what the hope would be is that they would see the value, they can see the outcomes, and that's good enough for them, to your point.
Yeah, Ken.
Thanks. I just wanted to let people know I've spoken with a VP at Optum who they want more coordinated specialty care programs to pilot test. They want to get more experience with how this works. So I just encourage anyone to to contact them or Kelsey or me. We can get them in contact.
Yeah. That's great. Was that recently? That's good to hear.
It was a few months back. Yeah.
Okay, yeah.
Yeah.
Which seems recent in the how insurance companies move.
Yeah, in the scheme of things, yes.
Well, we have time for maybe one or two more if there's anything else or any questions people have. It's really great to have you both in this space, I think, to hear kind of both sides of the story. Oh yeah, did Optum ask about fidelity? That's a good question. How are you guys managing that moving forward, if at all?
Or not, they didn't ask. I think and this might be again because we are clinical high risk. So
Mm.
we're not looking at like a navigate model. We're not holding to fidelity around navigate, right? What we are doing is we're talking about outcome data, right? So what they want to see isn't fidelity to a model per se. They want to see that their high utilizers, which they have identified as this population, are not utilizing inpatient units, right? Or going to the ER on multiple occasions. What they want to see is that when people are in this care, what we know about the care of coordinated specialty care is that being surrounded by a group of wraparound care is what helps people move towards recovery, not necessarily fidelity to the model, which one could say that fidelity helps with that, but because we're not doing that, we're not being held to that. And so that might look different for a FEP clinic, but not for us. So, and that wasn't really much of a conversation, actually.
Yeah, that's interesting. And well, I'm thinking to your point that you said before too, like you being able to say, hey, we're part of M3P, or for the first episode clinics to say, oh yeah, we're part of MapNet. We're in this community that has specialized training. We're working with the Department of Mental Health to assure fidelity, and we're using the standard assessment for outcomes.
I think that was enough, right? Like, I think that was enough for them to be like, oh, great, you are like I talked about M3P as a learning collaborative, and we cross-train across clinics, and we have consultations with each other. I actually think that was enough for them, and they didn't ask us to provide data around that at all. So, and again, it might look different for a FEP program. I'm not, yeah.
Yeah, but that's a great point.
Mm-hmm.
And yeah, Lauren, any surprises on your end in doing all of this?
Do I have surprises? I don't know. I mean, maybe I should have said I'm like coming from such an advocacy land. I came to the Kennedy Forum like almost 8 years ago now to run the state parity bill that included coordinated specialty care like explicitly in the bill. Before that, I was working at the courts and we were referring people to coordinated specialty care programs, but we couldn't refer commercial enrollers. So it feels like it's been a long, long time. And I think it does still surprise me how many people we work with through, like in California, what we've done is like, I worked at the state, I did this stuff, then I ran this bill, and then I worked with the regulators. You basically run through the whole gamut of anyone who would reasonably touch the like policy and legal landscape around CSC, so not necessarily providers. And it still surprises me how often we just have to explain what coordinated specialty care is and that it's covered and that it is the law. Like, to state agencies and to people that are like making pretty big decisions about coordinated specialty care and whether it should or shouldn't be covered in like Medicaid, for example, or things like that. So I think that always surprises me, and it just also goes to show like how often sometimes we're like talking on like level 800, but like we still just need to explain that first slide of like what coordinated specialty care is and why it's important, and it is the law and you must cover it. Like those things feel like conversations that we should maybe be beyond, but I think just the way that this is working, we're not. We're never beyond that. We always have to kind of root ourselves in that in conversations, and yeah, it can be surprising, but it's also grounding and like, oh yeah, the whole world doesn't revolve around my coordinated specialty care desires. People are like dealing with like, ACA stuff blowing up and all this stuff. So I think trying to situate, and as Amanda said earlier, like they're like, oh, this was like low priority for us. It's like, well, it's high priority for us. So
Yeah.
like having to continue to like push that it is high priority and explain why, I think can feel exhausting, but it's also just like, okay, it's like a reminder of your mission and that you have to do this stuff. So that always surprises me how often we kind of have to go back to basics. She says, as she probably gave way too much like wonky information in the beginning of the call, but yeah.
But it's all in the slides, which we'll share.
Almost
Yeah.
let's, yeah.
Yeah. Well, and that makes me think I have one maybe bigger question, but obviously right now we have existing clinics. We want to start using these rates with the clinics we have. In our role in MapNet, we also are in conversations with various people who don't have CSC but maybe want to start something. Do you think this process would be any different between kind of an existing clinic versus somebody who doesn't have CSC but wants to be able to provide those services?
Um, I mean, I think Amanda may have also some good opinions here. I
Mm.
don't think it necessarily matters. I know that a lot of people have done a lot of this in Medicaid, and that can make them more experts on how it works in Medicaid. But then on the other end, sometimes it can make it really hard to think about how else to do this work. And so if you're not billing for those things right now, or you don't have like existing contracts with Medicaid, or you're still building your program and you don't have a full like CSC model yet, like I don't think that's a reason not. I don't think you have to like do all these steps to get to the last one. And in some cases, it may like help the mental model of just like trying to think outside the box if you haven't done any of them. That's my guess, but I'm not a clinician, so I could be wrong in how hard that is to do.
Mm.
I think similarly, and I think like we like I guess one of my arguments would be like we don't have enough capacity to treat what we know is out there right now. So like if you want us to be sustainable and you want the capacity across the state, then you'll have to fund us. And part of like this team-based rate is that what we're doing right now is not working and it is not sustainable. So like how can a clinic start if it's not a sustainable model? So I think that there's something in there for an argument around like we will invest in the capacity building. You need to invest in the fact that we have a contract and that you can let the capacity building be sustainable. So like I think that there's something in there around that kind of contract. Yeah.
Yeah. Well, and yeah, the whole goal of this is to have scalability, sustainability, grow the service to meet the number of people who we know are not getting, CSC who need it. So
Yep.
yeah, thank you. I think that's a fantastic note to end on. Thank you both so much for your expertise. Thank you everyone for the great questions. Like I said, we'll be putting up the slides and Lauren, maybe some of the additional documentation you mentioned up on our website. So keep an eye out for that. But yeah, happy Friday, everyone. Thank you.
Thank you. Thank you, Lauren. It was nice to present with you.
Let's present with you.
Bye. Bye.